All right, it is 12 o'clock on the dot, so let's go ahead and get started. Good afternoon, everyone, and welcome to our Department of Medicine Grand Rounds. My name is Ryan Abe, and I'm one of the Medicine Chief Residents. Today, we have a special hybrid Grand Rounds broadcast live from Fred Hutch. So without further ado, I will turn over the stage to Dr. Dennis Apkowitz, who is the Clement A. Finch Professor of Medicine and the Division Head for Hematology, to introduce our speaker.
So thanks loads, Ryan. This is Jen Apkowitz, and I'm delighted to introduce today both Clem Finch, who this lecture is in honor of, and Michael Davan, who is the speaker. So Clem Finch was head of the Division of Hematology from 1949, when the medical school first started, until 1981, so for 32 years. And going forward. Okay, and he actually started at age 34. So the medical school was a different place back at his beginning as division head. And these are some other pictures of Clem from that time. He was a very prolific scientist as well as a fantastic physician. And some of his contributions included defining the iron kinetics and physiology of iron. He studied transferrin biology. He predicted the existence of mediators such as spiriportin, hepcidin, and rifaferone just by virtue of their physiologies. And then many years later, these mediators were cloned. He described red cell development and the physiology of anemia. He showed that hemochromatosis was due to the hyperabsorption of iron in the GI tract and could be treated with phlebotomy, just changing the course of that disease. He defined different ways and better ways of storing blood. And he helped WHO understand nutritional anemia in the developing world and championed iron supply in the food. So his studies I want to just talk about a little bit more have to do with nutrition and iron deficiency. So in 1959 to 1980s, he was a consultant for nutritional anemia on a study conducted by the World Health Organization. And he traveled to Kenya, Seychelles, and there's a whole list of other places he traveled at that point in time, which is quite unusual, and was awarded the 5th annual Bristol Myers Award for Distinguished Achievement in Nutrition in 1985. And this is a picture of that he took from Gambia in 1985 of his times there. So what are my memories of Clem? He was division head when I came here as a fellow. Very tall, both physically and in terms of his stature in the hematologic world. Extraordinarily smart, very creative with everything that he did with science and with his way of teaching. An absolute excellent observer and listener and a favorite of patients. Eclectic, both in his interests and also in his hobbies and how he dressed. Not shown here, but generally it was a bow tie and a Peruvian vest, and a very creative problem solver. And so with that in mind, we've since, for many years now, have had a Clem Finch visiting professor who's given both hematology grand rounds, Blood Club, which is our collection of people from the community and people from academics that are involved with hematology and oncology, and also medicine grand rounds. And so it's my pleasure today to introduce Dr. Michael Davan. So Mike got his BS in chemistry at Howard University, and then his MD at Stanford degree, his MD at Stanford, and along with an MS in health services research. He did a pediatric residency at Washington University, and then was chief resident in pediatrics there. He did an epidemiology fellowship afterwards at the NCI and getting an MPH at Johns Hopkins, and returned to Washington University, where he rose through the ranks of assistant professor, associate professor, and full professor before moving in 2010 to Vanderbilt, where he is currently. He is currently vice chair of clinical research in the Department of Pediatrics. And importantly to us, he's the founder and director of the Vanderbilt Meharry Center for Excellence in Sickle Cell Disease. Dr. Davan has many, many awards. In his early life, he had Robert Wood Johnson Fellowship, Doris Duke Fellowship, Doris Wellcome Fellowship. He has prizes such as the Beutler Prize for the American Society of Hematology, and a mentoring award as well. He's a super mentor. He's been very involved in patient care and patient decision-making and helping patients and their families make best decisions, as well as work here and work abroad. And he's been noted for this by membership in the ASCI and AAP and the National Academy of Medicine. He's an associate editor of Up to Date, writing about sickle cell disease in that context, and many of you have probably read that as well. So earlier this week, he's been meeting with people throughout the hematology community and giving several lectures on sickle cell and its various ramifications, and particularly the problems of silent stroke and changing the outcome and executive performance of folk that have this disorder. But today he's going to be talking about something that's related but a little bit different, which is academic activism. And with that, I'd like to introduce Dr. Davan.
All right, so thank you for that wonderful introduction and the honor of being here as a visiting professor. It's been a tremendous visit for me, and I must say that I strongly prefer the option of a face-to-face visit where I'm able to interact with so many of my peers, the fellows, and get a sense of the vibrancy that's at this wonderful medical center. I appreciate it. So I'm going to talk a little bit about academic activism. And I just want to mention that this is the outline for my talk. I'll give you a definition of activism. I'll talk about my experience in medical school, then my experience as a junior faculty member at Washington University School of Medicine, my mid-level faculty role. I had a midlife crisis in 2010, and I'm going to be honest about that. And then what am I going to do as winter is coming for me? So the background here is actually fairly important. Like, what is activism? And I've been focused on this topic for well over 15 years, but the definition has really not changed since I started giving this talk. And this was from Wikipedia. Activism consists of intentional action to bring about change in one or more of the following domains: environmental, social, political, or economic. And this sounds very academic, quite frankly. But in our household, it was basically not accepting status quo when you know you should and could do better. So I'm going to give you this journey, and you'll see that I made many mistakes in this process of trying to empower others and to live out this expectation of doing better and not accepting status quo. So I was a medical student at Stanford, and there's a young man who did not get accepted into medical school. I was on the admissions committee, and the comment in his chart was that the medical student should not be accepted because he lacked ambition and desire to travel abroad to learn a second language. And he was summarily rejected. So what did I know that the interviewer did not know? This was his first plane ride ever. And as he flew into DC, my wife and I picked him up. He had no pre-professional advice in terms of dress code, practice interviews, or the like. He was the first one in his family to finish high school. He worked as a full-time job while he finished college, and he had been 100% independent from any financial responsibility since he turned 18. So what did I do? I lobbied hard, real hard. I first went to the dean of admission and basically threw up his hand and said, "This is the decision that we've made." So then, for you all who are familiar with the Stanford decision-making process, they have a faculty senate who was, I'm sure his job description did not include listening to a third-year medical student complain about someone who did not get admitted to medical school, but that's who they sent me to. And I burned significant amount of ATP on focusing on the unfairness of this admission process and really the bias that was clear to me when this young man was not accepted. And I basically threw down the fighting words at that time. I said, "Look, if he is rejected, then your decision to accept me was a mistake." And at that time, I was doing fairly well at Stanford, and I really wanted to get across the point that there was really no difference between this applicant and myself. And it was only because of this biased interview that he received.
Recording in progress.
So the end result, is that okay? Okay. The end result, well, I'm hearing the echo, is that? So the end result was he was admitted to medical school at Stanford. He proved to be an outstanding medical student. He was one of 2 students that were nationally recognized and received a pre-doctoral award for neurosurgery research. He had multiple manuscripts as a medical student, and he matched in his #1 choice in neurosurgery. So I could give you about a dozen of these type of interactions of similar challenges throughout medical school and residency. And when I started my fellowship, I decided to change from the I will approach to we will approach. And this was an epiphany for me in terms of how to have the biggest impact and to initiate an approach for academic activism. So I'm skipping those years of training and going right into when I was hired as an assistant professor at Washington University and made it to associate professor from 1996 to 2003. And I was learning the status quo as a faculty member. And these were the observations. I was actually the clinical director of the Division of Hematology Oncology, practiced both oncology as well as hematology. And these were the observations. There was no camp for children with sickle cell disease, despite multiple camps for children with cancer, at least half a dozen. There was no social worker for children with sickle cell disease, and there was no effort by the American Red Cross to educate and improve the proportion of blood donations in the African American community. So, so this challenge for us was, I was taking care of children with cancer, and I literally had about 6 camps that I could refer to our families who wanted to enjoy the rite of passage of a child actually participating in camp. And I had no such camp for children with sickle cell disease. So what did I do? I ended up literally, with the hope and a prayer, putting a camp together outside of the jurisdiction of the medical center. I'm sure I broke every medical legal law at that time, starting this camp. We went to local philanthropic organizations. I went to local philanthropic organizations, pleaded to them our case. We were able to bootstrap this camp for children with sickle cell disease. The camp director was our social worker. The medical personnel every night was myself. The arts and crafts team was my wife and my daughter. And we just did it. And we did this, set this camp up for 9 years. And in the 10th year, the hospital elected to support this entity, and it's still sustainable to this date. So we also had no social worker for children with sickle cell disease. And I don't have to explain to this crowd the importance of having a social worker who is part of the team, who is anticipatory as opposed to reactionary to the challenges that students and children with sickle cell disease may have. So what was the landscape at the time when I was the clinical director? Brain tumors had a social worker, about 100 families of children who had brain tumors. Bone marrow transplant had a social worker, 25 children per year who had access to a full-time social worker dedicated to the transplant unit. The pediatric oncology unit had a social worker, which also included a separate one from the bone marrow transplant. And sometimes the bone marrow transplant social worker doubled in both units. But for sickle cell disease with 360 children and adolescents, there was no social worker. So what strategy did I take? I ended up writing a grant. And when you write a grant, you can put in any title you want. And so I put in the title of school liaison. And in fact, I hired a medical social worker with a master's degree. And our approach was to establish a different model for a social worker in our hospital system. As I mentioned, I wanted to focus on anticipatory rather than reactionary care for our children. She attended individual educational plans, the IEPs for our children with sickle cell disease, visited the schools, We made home visits to several of the families that were extremely high risk so that we can understand what their living situations were and actually meet with the families in their kitchen so that we could diffuse the power trade-offs when someone comes to a vast medical center and is sitting in a room where all the power really rests with the provider. And then, as I mentioned, she became the de facto camp director for the program. Here's some of the work that she initiated that was published, demonstrating her value to the system. Her first name was Sonia. She demonstrated the inadequate recognition of education resources required for high-risk students with sickle cell disease. And then she, as second author on this manuscript, Allison King, was actually a fellow at Washington University at the time, and demonstrating that a multidisciplinary healthcare team efforts to improve educational attainment in students with sickle cell anemia and strokes. Also, I was in a unique position. I've been fairly focused on sickle cell disease all my career, and one of the largest and most influential law firms in the Midwest approached me about our challenges with children with sickle cell disease. And so we were able to solicit their support, specifically in regards to obtaining an individual educational plan, a legal document that obligated the school district to provide the services for our children who had overt strokes, silent strokes, and learning disabilities. And I have to tell you that prior to this interaction, we had significant challenges in getting the school district to pay attention to our children who had clear learning disabilities, clear needs of special resources. And after we had the support of Brian Cave in the letter with their letterhead, instead of taking months or even years of being ignored, we would usually receive a response within 5 days of the letter being mailed from the school district. So what's the permanent result of this effort? Well, a social worker was hired as a permanent member of St. Louis Children's social work staff. And now, as of this date, 2022, they continue to have a social worker allocated specifically and solely to the care of children and adolescents with sickle cell disease. So this slide is a little bit different from the earlier slide that I may have shown to the group. This was a series of questions that I was peppered with when I was a fellow by the teacher. The first question was, what is wrong with this student who had lost her academic milestones? And with that simple question, I've developed a career on focusing on the definition and the impact of silent cerebral infarcts in children with sickle cell disease, and this was at St. Louis Children's Hospital. Why did this occur? Again, leaned on my colleagues, Bob McKinstry, who's a radiologist, and Lori Jordan, a former mentee and now a collaborator, to understand the basis for why silent strokes and overt strokes occur in children with sickle cell disease. And Lori is now an associate professor with tenure at Vanderbilt, a recent inductee into the American Society of Clinical Investigation. What can you do to treat this young lady who's had a silent stroke? And we completed our silent infarct transfusion trial, and the credit goes to a magnificent team, including the staff at St. Louis Children's Hospital. And then as we have demonstrated that transfusions are helpful in decreasing the rate of progression of silent infarcts to overt strokes or silent infarcts, they're not the definitive treatment. It's considered palliative. And so we migrated to using curative therapy and bone marrow transplant with my colleague, initially mentee and now collaborator and very close friend, Adetola Kassim and Robert Brodsky. And with that, we've been funded by the BMT-CTN, and we have private philanthropy funding from the Vanderbilt Haploidentical Transplant Consortium. And then last is, how can I help this child learn? These were all questions that were peppered to me when I was a fellow, trying to identify my career trajectory. Allison King, who's been a mentee and collaborator and friend since her internship year in 1996, has gone on to get a PhD in education, and it focuses on strategies, evidence-based strategies for education improvement and attainment in students with sickle cell disease. And I'd like to show you this slide of the teacher who peppered me with these questions and had high expectations that I would actually address them. And that's my mom. She was a Montessori teacher and a special education teacher prior to that. And I had the opportunity to work with my mom for 6 weeks as a high school senior as part of my service project. And it was there where I learned firsthand the challenges of a teacher who has to support a child with a learning disability and needed to develop a curriculum for them that had to be individualized based on their educational attainment profile. And here's the end result of actually a decade of a trial and a previous decade of proving the point to others that silence-mediated infarcts were clinically relevant to children with sickle cell disease. And that was published in the New England Journal of Medicine. And what we demonstrated was that regular blood transfusions, when compared to observation, decreased the relative risk of infarct recurrence, overt or silent stroke, by 56%. But what I actually want to talk to you about is the participants in this trial. The yearly income per capita was $8,500. I want you to think about that for a second. That means for a family of 3, they're getting by on less than 26 grand a year. And this is what we asked our families to do. 86% of those individuals who signed up for this trial agreed to and followed up with monthly transfusions for 3 years. 3 MRIs of the head, all non-sedated. 4 neurology evaluations by pediatric neurologists, 3 cognitive tests, 2 quality of life assessments. 9% of the families completed partial data on exit. 86% completed all of the metrics I just mentioned. And only 5% did not complete any exit data. Really pointing and highlighting that the African-American community will participate in clinical trials that are as arduous as any clinical trial that you would have in a pediatric population without financial resources. The key to this success of this trial was really the homework that we did prior to the trial to make sure that we made the trial as user-friendly as possible, explain the trial in both a written language as well as ensuring that at each one of these locations where the trial was being conducted, that the care for this child would not be compromised if the family chose not to participate. And these were all very strong sickle cell programs across not only North America, but Europe. So I'm going to turn the attention to one of the main challenges that I had to face as a faculty member, managing children with sickle cell disease and young adults with sickle cell disease who needed blood transfusion. And the main problem is, if blood is the only therapy for primary and secondary prevention of strokes, how can we decrease the rate of red blood cell alloimmunization? The solution was pretty straightforward. You have to increase the number of African-American blood donors, who would then be logically the best minor red blood cell antigen match. So it turns out that in St. Louis, there's the Missouri, Illinois American Red Cross. They had no effort ever. Like 1999, there was no effort to educate the African-American community about the importance of blood donation. I'm not even sure that you can put your arms around that. 0 effort. And before I started asking the question, they had no record of collecting blood donation from African-American communities. It wasn't a priority. It wasn't even part of their campaign to improve blood donations in the community. And so one of the challenges that we all faced was this challenge of discrimination, quite frankly, bigotry at the individual level and racism at the systemic level, demonstrating that the American Red Cross was literally was the group that labeled the blood black or white, because in fact, there was a perception that the white soldiers should not receive the black blood and the black soldiers could not receive the white blood. And here's a cartoon taken from that era. It says, geez, looks like the colored lads is the only ones that's got round trip tickets at the hospital today. And then you can see the caption underneath saying, guess they only got Negro blood. We got to wait if we can. Last. So we set up a program called the Charles Drew Community Blood Donation Program. This is me with one of the patients that we set it up for. And for those, the irony of this is Charles Drew was a Black man, and he was the head of the American, he was the medical director of the American Red Cross that was a advocate for separating blood. And he was the individual who actually pioneered plasma collection that was used to save the Brits in the field when they needed colloid to improve their circulation due to obvious combat injuries. The focus was on children with sickle cell disease who had strokes who required 15 and 25 transfusions a year. And we were looking for the best match blood from the African-American community. And then we actually set up a direct donor program where literally individuals would be called anywhere between 3 to 5 days of the scheduled transfusion, because we wanted those units to be as fresh as possible because they would last longer. And we made this a community activity for an entire St. Louis metropolitan area. And then we wanted to increase the total number of African-American blood donations for the region, because it is the right thing to do. As a hematologist, we know the importance of blood donations for so many different reasons in a hospital setting. So what were the highlights? We educated the African-American community routinely. We identified the barriers of blood donations for African-Americans. We developed an outreach program for and within the community. We had established 2 programs, one is which was referred to as the Sickle Cell Sabbath program that was ran for about a decade. And the program that's still ongoing is the Charles Drew program in St. Louis. As recently as less than a year ago, they continue to have the advertisement and marketing strategy to improve African-American donations in St. Louis. Here's one of the manuscripts that we published in AJH, trying to identify specifically what are the barriers for blood donation in the African-American community. And we identified that it was too inconvenient. It turns out the American Red Cross had no blood donor units or facilities in the heart of St. Louis. And St. Louis is just as segregated as any city in the South. There were zip codes where 99% Black, based on census data, multiple zip codes. And no American Red Cross blood donor facility in those regions. They're afraid of needles. It takes too much time. And there was concern about they might contract the disease. So here's our campaign strategy with Sickle Cell Sabbath. We're very well-known pastor in St. Louis. The results of the Sickle Cell Sabbath are seen here. Cindy Price was a research coordinator in our lab. Michael Johnson was actually an individual with sickle cell disease that participated. Terry Lindsay was a nurse practitioner in our team. Doug Dalton was a high school student. One of the goals was to support the high school students in the region to teach them about the importance of research and service to our community. Our hypothesis was that when informed at church about the importance of blood donation, African Americans will have a higher than expected rate of first-time blood donations when compared to the general population. We had 13 African American churches that sponsored exactly 34 blood drives from 2003 to 2006. Each church sponsored at least 2 blood drives. We had approximately 1,200 donors participated in the sickle cell blood drives. Most of the donors were first-time donors that represented a greater than expected first-time donor rate when compared to the first-time donors in the metropolitan area. And I'll show you the graph here. And you can see the number of first-time donors in this population, 699 first-time donors. And for those who know the world of blood donation, the first step is getting that first donor in and then getting them to come back. And so there's a tremendous achievement by the team. And then, as you can see, the comparison was only about 12% of the general population, non-African-American population, were first-time donors. So now I'm going to move forward. I am professor of pediatrics. I was professor of pediatrics, biostats, and neurology at WashU. And this is from 2007 to 2010. And I had an endowed chair. But I was agitated And I didn't feel as if I was serving my purpose and the ethos of which I had grown up with. So I had a midlife crisis as I started to look internal. And I had actually two questions that I wanted to address. I'm only giving you one of those two, but I'm happy to discuss the other, which is why is there no concerted effort to advance the medical care of children and adults with sickle cell disease in Africa, where over 70% of the children are born? So here's a cartogram that's well known to the hematologists out there. And this is the expected number of children born with sickle cell anemia, homozygous SS. And in the United States, you'll have about 1,400 children born with sickle cell anemia a year. In Nigeria alone, 150,000. And of note, in India, about 40,000 children are born with sickle cell anemia per year. So I was invited to go to northern Nigeria, Katsina, where we set up a camp for children with sickle cell disease. The first part of the trip was the traditional visiting professor, where every day I was talking to a group of professionals about sickle cell disease, and I agreed to give my time under only one condition: that after the end of this trip, that they would sponsor, the host would sponsor a retreat, a family retreat, a retreat specifically for girls with sickle cell disease. And in part, there are many different reasons for that, but I would also brought my wife and my daughter along, and my colleague's wife and daughter accompanied us. And they were the directors of this retreat for girls with sickle cell disease. And the truth is, I thought that I would have Saturday and Sunday off, but it turns out that these families came in from all over Nigeria, and they were not, this state, and they were not literally going to leave their daughters in front of these Americans. So they kind of stayed at the retreat on Saturday, and my wife came back to the hotel and says, you got to come in tomorrow. I went, wait a minute, I got tomorrow. No, because I had to catch up on my other work. Said, no, the families are here, and they're kind of clogging up the system with looking over the shoulders of the girls and asking questions and not letting the girls be girls during this retreat. And so I had the job for 8 hours to entertain the parents. And so it was during this time period that I was able to identify that, unbeknownst to the families, 6 of the 42 girls had a stroke. You can imagine making a diagnosis of a stroke on any single day for a child with sickle cell disease is a very sincere challenge, and to describe the implications. But in this particular setting, the families were unaware of the implications of first having a stroke, and then the future implications of the risk of having a second or a third stroke without any treatment at all. So what's the challenge in Nigeria? So for children with abnormal TCD velocities, this is a strategy that we use to screen children with overt strokes. The transcranial Doppler is put up to the middle cerebral artery. The incidence of a stroke for children with abnormal velocities in the middle cerebral artery is 10 events per 100 patient years. So about 10% of the children will have a stroke within a year if they're not treated. And then strokes in children without sickle cell anemia are significantly less than 1 event per 100 patient years. If you just look at the public health impact of strokes in this patient population, for every birth cohort of 150,000 children with sickle cell anemia, you can expect by the time they reach their 18th birthday that 15,000 children will develop a stroke. And then of those children who've had a stroke, 50% will have a stroke recurrence if there's no treatment. So the critical question is, can we prevent strokes in children living in Nigeria with sickle cell anemia? This study was published by Bob Adams. It's a seminal study in the field. And he took a group of children in the United States with abnormal TCDs, abnormal transcranial Doppler velocities, half of which he transfused, the other which he observed. And the end result of that was a 92% relative risk reduction in a group of children who received regular blood transfusion therapy. So this is transformative in the care of children with sickle cell disease living in the United States. The only challenge was it required monthly transfusions for an indefinite period of time. But what are the challenges of regular blood transfusion in sub-Saharan Africa? First, it includes, but it's not limited to, inadequate blood supply, the cost of the monthly blood transfusions, the unsafe transfusion practices, which is not talked about publicly, because quite frankly, it is a significant challenge, and then the high probability of blood-borne infections. The additional challenge is extreme poverty that we don't actually hear anyone talk about. In Nigeria, 40% of the population, 83 million, live on approximately $1 a day. Today, or as of March of 2022, the cost of the CDC for monitoring for hydroxyurea is actually $5. And the cost of the European produced hydroxyurea is between 50 cents and $1 a day. And you can see why pharmaceutical companies would be very interested in getting into Africa for treatment of therapy, because you just don't have a population that is as vast, as large with sickle cell disease as you do on the continent of Africa. So I'm skipping multiple years of work and just providing you with the punchline for our spring trial. This is stroke prevention in Nigeria. It was funded as an R1 in 2015, and we finished the results in 2021. The hypothesis was that the daily hydroxyurea at a fixed moderate dose of 20 milligrams per kilogram will result in a 66% relative risk reduction for permanent strokes, decreasing 9 events per 100 patient years to 3 events per 100 patient years in children with abnormal transcranial Doppler velocities when compared to daily fixed low dose. Now, I've interacted with the fellows quite a bit, and really the cornerstone of any of these studies, like it is for any type of research, is what is the hypothesis. So I was highly sensitive to the importance of setting up a hypothesis that would be sustainable after we finish. So it wasn't just a scientific question, but it was also the question of, when we're done, will there be a process by which we can implement stroke prevention outside of the setting of the clinical trial? So essentially here was the premise. If 20 milligrams per kilogram per day was superior to 10 milligrams per kilogram per day, we know the minimum hydroxyurea dose needed to prevent strokes in children with sickle cell anemia. However, if 20 milligrams per kilogram per day was no better than 10, the government can treat twice as many children with sickle cell anemia to prevent strokes for the same cost. Now, I said the government. At the time that I started this trial, I did not have a relationship, and we had not negotiated with the government to pick up the cost of hydroxyurea. In fact, the government had not picked up any cost for any medication in any of the 3 states that we were working with. But I tend to be somewhat of a Don Quixote in believing in things that people can't see. And so we actually worked very, very hard with the state government to support the program if we found results that were indicative of our ability to prevent strokes in children with sickle cell anemia. And then for those hematologists out there, the maximum tolerated dose of hydroxyurea, usually between 25 and 35 milligrams per kilogram, was really never an option in this patient population. The hematologists or the pediatricians refused to endorse this strategy because it was too labor intensive. They didn't have the expertise. They didn't have the nursing support. And then they knew that the majority of families could not afford to come in for monitoring of the laboratories required when you titrate the dose to maximum tolerated dose. Here's the end result of the work that was published in Lancet Hematology: hydroxyurea for pulmonary stroke prevention in children with sickle cell anemia in Nigeria, double-blind, multi-center randomized phase 3 trial. I want to show you the surrogate markers because I want to highlight again the importance of what your primary endpoint is. So we elected that the primary endpoint would be a stroke and not the surrogate markers for a risk of a stroke. And so the surrogate markers for a risk of a stroke, as I mentioned, is actually the transcranial Doppler velocity. What you have here is in the blue, the group of patients in the low dose group, and the red are the group of patients in the moderate dose group. We originally had approximately 220 patients who were randomly allocated, but we only included the patients that we could follow throughout in this graph who had measurements at baseline at 3 months and at study exit. I leaned on my oncology background, as we do for many patients with 1 month response. We off with leukemia to look for MRD, minimum residual disease. I elected to look at the TCD at 3 months, which was not standard, to see, in fact, if there was any response to the hydroxyurea treatment. And what you can see here quite nicely is that there is a response to the hydroxyurea at both doses, and but clearly a lower dose. The higher dose had a lower mean TCD velocity when compared to the group with 10 milligrams per kilogram per day. And then as we follow these patients upon exit with the median of 2.6 years, you can see again that the hydroxyurea with 20 milligrams per kilogram had a significantly lower dose TCD velocity when compared to the patients who received 10 milligrams per kilogram. So if we had focused our results on the surrogate markers, we would have said that 20 milligrams per kilogram was superior to 10 milligrams per kilogram. However, we chose as our primary outcome in this trial the occurrence of a stroke. And the results are as follows. In the low dose group, the incidence rate per 100 patient years was 1.1 strokes, whereas in the moderate group, it was 1.92. The incidence rate ratio was 1.6, and the p-value was 0.768. So if we had compared the stroke trial expected rates in the observation group, we would have expected about 10.7 stroke events per 100 patient years. And in the regular blood transfusion group, we would have expected 0.9 events per 100 patient years. So you can see that at least the low dose and the moderate dose are comparable, maybe not statistically significantly different than transfusions, but at least reasonable as a strategy to initiate in children who live in this region of the world where transfusions are not a reality. Of course, anytime you conduct a trial in Africa, there's always going to be this suspect that you did not conduct it precisely. And in fact, we were prepared for that criticism. These children were seen monthly. All of the research staff and the physicians were certified to perform the pediatric NIH stroke scale. They were evaluated every visit monthly for their neurological outcome. And any child that had an abnormal concern for a stroke or focal neurological deficit, they were videoed and they were adjudicated by Lori Jordan, the neurologist and multiple PI at Vanderbilt. There was no discordance, I'm happy to report, between the local team's adjudication of a stroke and that of the pediatric neurologist and the team. So the conclusion from the spring trial was that standard care for primary stroke prevention for 40,000 children with sickle cell disease in the 3-state region now includes free TCD measurements in 9 clinics across the 3 states, free state government-sponsored hydroxyurea starting at 10 milligrams per kilogram per day, and they have changed their practice to include biannual CBCs for this patient population, as would be expected in routine care for children living in the area. And then I'm happy to report that we were able to identify a Nigerian pharmaceutical company that had already agreed to provide hydroxyurea at 15 cents for a 500 milligram capsule. And I met with the CEO of this company, and he is overly enthusiastic about supporting the people from his own country and ensuring that they have access to his therapy at the subsidized cost. And his son is taking over for him. He's in his 80s, and he's also given me assuredness that he will do the same. So after the trial is over and the funding is gone, now what? And so sustainability of the work that I've done, we have always done together with others, is focused on what can we do? And we usually start with the end in mind for all the projects. And here's an example of this practice. Currently, we have set up a standard of care TCD screening at these sites. The TCDs, we have 18 TCDs in this region. All the TCDs are done free of charge for the families. We've now completed over 10,000 TCDs in this patient population across these states. We've identified a total of 743 children with abnormal TCDs. The prevalence of an abnormal TCD is 7.3%. And by the way, I didn't mention it, but I should at least mention it. All of the TCD ultrasonographers have had passed a competency test that is set up throughout this region, allowing for us to have confidence that the results are accurate. And then 99% of the children with an abnormal TCD have actually been placed on hydroxyurea. What about capacity building? So 3 of the mentees have gone on to receive funding. One has just recently received a PhD in epidemiology for UAB, University of Alabama at Birmingham School of Public Health. One received the K43, which is a mentored award for implementation science and stroke prevention in Kaduna. Her co-mentor is actually Allison King, my first mentee as a faculty member at WashU in 1996 when she was an intern. We have an ASH Global Research Award with a randomized controlled trial on preventing priapism in men with sickle cell disease with a young man that I'm mentoring in Kano. For those who may not know, but Dr. Arthur Burnett is an international expert on priapism and urological complications. He's a professor at Johns Hopkins School of Medicine and has the Walsh Endowed Chair in Urology. We also paid a lot of attention to the research staff. We developed a program specifically to get the research staff educated about research procedures and research governance. Each one of the sites has at least one person trained as a SOCA certified research individual. That process was a journey in and of itself because no one had actually been trained in SOCA and certified in SOCA practices and certified on the continent. They all took the exam and eventually all passed. They have an active SOCA chapter to ensure ongoing education about research governance for the research team. We generated over $5.5 million in NIH funding, the majority of that funding going to the teams in Nigeria. We completed 3 stroke prevention trials, and I've only mentioned one of them. We've developed a partnership with St. Jude and the teaching hospital in Kano, almost a twinning project, if you will, between a super academic center and the teaching hospital in northern Nigeria. We've set up a newborn screening program with premarital genetic counseling that has received the sanction of the Emir and the other religious leaders to allow us to support the premarital genetic counseling. We've established a clinic for children under 7 to decrease the mortality and morbidity. And we conducted the first NIH-funded randomized controlled trial for the treatment of malnutrition in children with sickle cell anemia, not less than 5, which is what the WHO recommends, but actually between 5 and 12. And in our spring trial, 27% of the children between 5 and 12 had severe acute malnutrition. So this is really a challenge for all of us when we start to think about how do we manage children who have both sickle cell disease and severe acute malnutrition. So here's the team. This is the we part of how I was able to transform from an I part. And you can see we are actually vast. And they literally was the best clinical research team I've ever worked with. And I've worked with a lot of teams from different regions of the world. And their commitment was second to none. And this gentleman in the middle here, that is Dr. Arthur Burnett, the urologist who is working with me and other members of the team to address this devastating problem of priapism in men with sickle cell disease. So I'll switch gears for a bit. I have done some work and continue to do work with the team in Ghana. This is the Kalibu Teaching Hospital, which is the premier flagship hospital for Ghana. And in this setting, we decided to focus on the decrease in maternal mortality of pregnant women with sickle cell disease. And I just need to give you a sense of what this number looks like. In the United States, the way that public health officials describe maternal mortality, that is pregnant women who die, is per 100,000 live births. And in Northern European countries, that number is typically in the single digits, 7, 8, 9, sometimes even 2. In the United States, it can be anywhere from 15 to 25. In Ghana, for women with sickle cell disease that average between 150 to 200 deliveries per year at the flagship hospital. The mortality rate was 10,000 per 100,000 live births. So we put together a multidisciplinary team. There's very few things that I will do in my career that I think will have such an impact on the lives of others. I was very excited. I submitted it to our flagship medical journal, Blood, and it was summarily rejected. And I would tell you, I just was baffled. I said, like, what am I ever going to do that's more important than this? And it can't go into Blood. And it was a prospective study. And I'm happy to say that when I had a conversation with this Arthur Donald McNeil, a reporter from the New York Times, he said, "Oh, don't worry about it. Our circulation is much bigger than Blood's." And he wrote an article about our work. And what we demonstrated there was that we could decrease the maternal mortality rate by 90%. And this was in 2017. And then I'm happy to report, again, this is the we strategy, and these are the members of the team, that in Blood Advances, we just had a short letter documenting that outside of this prospective cohort study, we were still able to maintain the ability to decrease the maternal mortality rate to 1,000 deaths per 100,000 live births. And these are the members of the team. And I think it's actually quite instructive to describe to you who the we are. This is Adatola, the gentleman right, I don't know if this is showing up, but the gentleman right here with the purple shirt, he's my colleague and friend, and he's the adult hematologist for our Sickle Cell Disease Center. This is Charles. He's an adult pulmonologist and intensivist and anesthesiologist, just received his PhD from the University of Amsterdam Medical Center. And he's come back to Ghana, and he manages the lung disease in this patient population. And the number one cause of death was actually acute chest syndrome. 80% of the deaths were associated with acute chest syndrome in his women. And this is one of the nurses that I worked with when I was the clinical director at WashU. She was the medical assistant, went on to become a nurse with a lot of encouragement and support. And I brought her over, even though I was at Vanderbilt, to WashU. I'm from WashU because she's so extraordinary, and there needs to be peer-to-peer interaction between the nurses. And this is Samuel Palm, now the head of OBGYN, and the young man that approached me in 2014 to put the work together. And the others are members of the teams. Eugenia Asari received the ASH Global Research Award. And Charles is the gentleman who handles the majority of the OBGYN care for pregnant women with sickle cell disease. So I want to end with the tumultuous summer of 2020, when we were all a little shocked about the face of America, across America. And so I was faced with this challenge of how do I march? So, so a little background, when I left WashU, I had picked up many of the skill sets that others had informally demonstrated, not with any deliberate action, but with me asking a lot of questions about how you become successful in an academic center. And what was clear to me that at Vanderbilt, there was a lack of continuity, particularly for the Black faculty. So I reached out to a colleague of mine who was a member of the National Academy of Medicine, another senior Black faculty person, and we started a breakfast club. We met quarterly, and we identified the three people that clearly were on a trajectory to become physician scientists, but were hitting a couple speed bumps in their career. And so we had frank conversations, everything from how to write a names page to what honorific societies they consider. What do you do when your grant is rejected? What do you do when your division chief is not supporting your science, but others believe you have the best science available in the field? And give a lot of counsel. And so the end result of this in terms of hard numbers was that we increased the accepted manuscripts from 22 to 52. We increased the funding from 1.34 to 2.01. But probably more important than the numbers is that each one of these individuals have gone on to achieve outstanding accomplishments to support their career trajectory. The department chair of OBGYN now at WashU was somebody that was kind of left out to pastures and thought that she was not going to be an accomplished physician scientist, and she actually has several R1s at this point. There's the chief of pediatric infectious disease at the University of Buffalo. And then Dr. Wanda Drake is at Sarcoidosis Center of Excellence, multiple R01s, a celebrated physician scientist. And during that summer of 2020, I reached out to Wanda, who was the recipient of that interaction for the previous years, and said, gosh, we got a whole new cohort of folks out here who neither you are not, nor I know. Let's reach out. And we've started a breakfast club. We call it the last Wednesday of the month breakfast club. And we have to meet at 6:30 in the morning because of so many competing obligations, particularly for some of the surgeons. So also at Vanderbilt, I was able to set up a Vanderbilt Meharry Pediatric Scholarship Program. These were the people who were recipients of this program. There were 5 students. And I must tell you, they were distraught during that summer, including asking me questions regarding like, what would it take for us to be physicians in another country? What is it like to live in another country? And really it was their energy that prompted me to say, look, we can do better. And we ended up, based on really their inspiration, I wrote a grant that summer to expand this program. For those who don't know, Meharry is a historical Black college, probably about 90 to 110 students come in. Their match day is probably one of the most spiritual events I've seen in any medical school, because you end up listening to the stories of people, students who will become physicians, where their entire family moves to Nashville to support them in their journey, where they are the first in their family to finish high school, let alone college, let alone become physicians. So reach back out to my colleagues in internal medicine. Wanda Drake, the young lady who was I worked with for the Breakfast Club, is now multiple PI with me on this grant. We have funded by the Barrels Welcome Fund. The head of pediatrics and the head of medicine agreed to expand the program, allow us to have cost share for our salaries so that we can actually put additional time in. The previous 5 years was no cost share. And then we have a 1-year pull-out. And so we can identify Meharry students who are doing excellent in the research lab, who want to pursue the career of a physician scientist. And we have funding from not only the Barrels Welcome Fund, but also from the president of Meharry Medical School for 2 students to have a 1-year pull-out. And we're looking for the best fit. We don't really care whether that best fit is at Vanderbilt or UW or Fred Hutch. We're looking for the student who's motivated, who wants to become a physician leader or a physician scientist. So I've tried to give you this approach that I've taken to go from the I to the we in my journey for academic activism, and really have walked away from the individual activity and really focused on the we approach. And with this increased effort, you can see that hopefully the work will stand the test of time, particularly for the group of mentees who have embraced the same philosophy. Many people to thank. I just cannot tell you how, without my wife, who's my best friend, and someone that I bounce a lot of these ideas off of, either deliberately or as wives do, non-deliberately. She holds me accountable to the principles that we both grew up with and that we have grown together to cherish. Our son and daughter, Malcolm and Morgan, the rest of my family, my mentees, my extended family of brothers, the St. Louis Children's Sickle Cell Disease Research Team, we were an island in that environment, and we did well, and I appreciate their effort. And the VUMC research team, obviously the Nigerian Ghana research team, and then most importantly, the families of children with sickle cell disease. This is me and Cassina. One of these boys has sickle cell disease, and our goal is to make it clear that you won't be able to determine which one. So thank you very much.
Dr. Davan, I wanted to thank you so much for sharing your journey from both a scientific discovery perspective, advocacy, community building. There are so many lessons that we can learn from this. We have about 1 minute left, and so we probably have time for one question. Reading from the chat here. Let me see here. It seems you mentioned being published in the New York Times. and how the circulation is greater than medical journals oftentimes. It seems like a good idea for any researcher to get published in both sort of medical and lay media. Do you agree with this? And do you have any ideas about how we can distribute our work in the lay media?
Yeah, I'm actually, I know this sounds contradictory. I celebrated the fact I got it in the New York Times. I sent it to everybody in my family. But the reality is, I'm not in favor of science being promoted through press releases in the media, because I'm not sure that you are able to represent the full story, the scientific story, which includes the limitations, the actual data, and the like. And so, despite me touting the New York Times article, it still was published in the American Journal of Hematology. So it still was published, but not in blood.
Great advice. Thank you so much. And we're right at 1 o'clock, so I wanted to go ahead and end our grand rounds there. Thank you again for our speaker, and have a good week, everybody. Take care.